Hello, I am Dr Samim, pediatrician from Safdarjung Hospital, New Delhi. Today I will discuss a small topic about Hirschsprung disease in detail. I have divided this lecture in several parts: definition and epidemiology, pathogenesis, types, clinical feature, examination, investigation, and management. Hirschsprung disease is also known as congenital aganglionic megacolon. It is congenital developmental disorder of gut characterized by reduced or absent peristalsis due to absence of ganglion cell in the intestine, causing functional obstruction of gut. These ganglion cells present in Auerbach's plexus and the Meissner's plexus. Auerbach's plexus, also known as Myenteric plexus, they present between the inner circular and the outer longitudinal muscle layer of the intestine, and Meissner's plexus present in the submucosal layer. Then it is most common. Hirschsprung disease is the most common cause of lower intestinal obstruction in neonate. Incidence 1 in 5,000 live birth. Hirschsprung disease more commonly present in term babies than preterm babies. And gender predilection, it is more common in the male than female. Pathogenesis of Hirschsprung disease. Normally, ganglion cell arise from primitive neural crest, and at 5 to 12 weeks of gestation, this ganglion cell migrate to gut. But failure of this migration leads to lack of ganglion cell in the gut. So there is lack of intrinsic nervous system innervation in the gut. So there will be unopposed extrinsic nervous system innervation that cause contraction of the affected segment. That is the part that lack the intrinsic nervous system innervation or lack of the ganglion cell. Pathology of Hirschsprung disease. If we do histopathological examination of the affected segment of Hirschsprung disease, then we will see absence of ganglion cell, hypertrophy of the nerve fiber and nerve roots, and increased staining of the acetylcholinesterase, which is 6 times more than normal. Types of Hirschsprung disease are based on the location of the affected area. 80% of Hirschsprung disease are classic disease or short segment disease. They involve the rectosigmoid region, and 10 to 15% are long segment disease. They involve the distal colon and extends proximally to involve the sigmoid flexure of colon. 5% is total bowel aganglionosis, that is also known as Julzer-Wilson syndrome. There is a very rare type, this is called ultra short segment Hirschsprung disease. They involve the anal region and also known as anal achalasia. Clinical features of Hirschsprung disease. 80% of Hirschsprung disease present in the neonatal period and only 20% present in the pediatric age group. And most common clinical feature of neonatal Hirschsprung disease is failure to pass meconium in first 48 hours of life. Abdominal distension, bilious vomiting, and formula fed babies are more commonly affected than breastfed babies. 10 to 20% of Hirschsprung disease present in late infancy or childhood. They present with constipation, failure to thrive due to protein losing enteropathy, and stools are ribbon-like or pellet-like and often foul-smelling when passed. Visible peristalsis present, and intermittent intestinal obstruction-like features also present in late presentation Hirschsprung disease. Complications of Hirschsprung disease. If Hirschsprung disease left untreated, there will be development of complications. These are enterocolitis. This is most common cause of death in Hirschsprung disease. There will be profuse watery bloody stools. Then bowel perforation and ischemia, sepsis, and urinary retention and hydronephrosis. After the history and clinical features suggestive of Hirschsprung disease, we have to do DRE, that is digital rectal examination. If we put small finger into the anus of the child, we can find that anal canal and rectum empty and narrow, and it grip the finger. On withdrawal of the finger, there is sudden gush of explosive, offensive stool and gas. This is called square sign or blast sign. Common investigations done in Hirschsprung diseases are unprepared barium enema X-ray of abdomen or plain X-ray abdomen, rectal manometry which show elevated anal tone and absence of RAIR, that is rectoanal inhibitory reflex. Rectoanal inhibitory reflex normally present, but in case of Hirschsprung disease it is absent. And third is rectal suction biopsy, and it is the gold standard test for diagnosis of Hirschsprung disease. If we do barium enema X-ray abdomen of Hirschsprung disease child, we can find three zones. Proximal one, most proximal one is dilated proximal segment. This is the normal gut. Then second one is constricting transitional zone. Constricting transitional zone. And third one is constricted distal segment. This is aganglionic part. Here is absence of the Auerbach's plexus and the Meissner's plexus due to failure of migration of neuroblast from proximal to distal bowel. So this part is constricted due to unopposed innervation of the extrinsic nervous system. Rectal suction biopsy is gold standard test for diagnosis of Hirschsprung disease. If we do rectal suction biopsy, we can find absence of ganglion cell, hypertrophy of the nerve fibers and nerve roots, and increased staining with acetylcholinesterase. Biopsy is taken 2 cm above the dentate line. As why 2 cm above the dentate line? Because below the dentate line, ganglion cells are absent normally, and biopsy should include the submucosa because Meissner's plexus present in the submucosal layer. If rectal suction biopsy is equivocal, then we have to do full thickness rectal biopsy followed by calretinine staining, which show absence of staining here. This is the image of full thickness rectal biopsy. Why full thickness rectal biopsy is better than rectal suction biopsy? Because rectal suction biopsy include either the Meissner's plexus or Auerbach's plexus, but full thickness rectal biopsy include both the Meissner's plexus and the Auerbach's plexus. Lastly, we will discuss the management part of Hirschsprung disease. Mainstay of management is surgical resection with temporal colostomy and definitive repair at 6 to 12 months of age. There are 3 surgical procedures which can be done: Swanson procedure, Duhamel procedure, and Soap's procedure. But Soap's procedure is procedure of choice. It is laparoscopic endorectal pull-through procedure. What is done in this procedure? Mucosa of the aganglionic segment is stripped first and then pull the normal colon down through the muscular collar left behind. Thank you guys. Hope you enjoyed this video.